destroyed, some of it, and the bone loss. So the whole thing, just the whole attachment will move epically. Bone, connective tissue, junctional epithelium. That's when we have attachment loss. So the answer to that is when the base of the pocket is apical to the CEJ. Okay, so this is actually will be a surgical view. We reflected the flap, we degranulated the area, and now we're looking to see how the bone looks like. And these round circles are the roots, and in between where it says 1, 2, 3 is the interproximal area. And now we have, are these infrabony defects or horizontal defects? When we have 2 wall, 3 wall, 1 wall, are we talking about horizontal bone loss or vertical bone loss? Vertical bone loss. Because horizontal bone loss is even. We don't have any walls. It's just the crest of the bone is resorbed perpendicular to the root. So which defect would you like to regenerate bone in? 3 wall. Good. Who answered that? Okay. What about the 1 wall? Is it as predictable in regeneration? No. You will have some of these questions probably on the board. So, regeneration in 3 wall defect is more predictable and it works better than a 1 wall or 2 wall. If we have a class 2 furcation involvement on the buccal of number 30, and a class 2 furcation on the distal of number 14. And I'm going to do regeneration. Which one is more predictable? Mandibular furcations or maxillary furcations? And that's another question in the board. Mandibular, usually it's mandibular furcation. Class 2. Can we regenerate class 3 furcation involvement? No, it's not amenable to regeneration. So, this is part of Dr. Ashrafi's lecture about regeneration, where we have 3 walls, and where are the 3 walls? Where is line number 1? What is that line? Where is it located? Remember, these are the teeth. We're taking a close-out kind of view. That's the interproximal area, and the tooth in the bottom is tooth number 30. The tooth in the top where it says 3W is tooth number 29. Okay, so, and this is buccal. No, this is lingual. This is buccal. Number 1 is, what wall is that? Is that the lingual? That's a lingual wall. There is still a wall from the lingual. There's lingual bone in there. What is number 3, line number 3? That's a mesial. That's a distal to number 29, but mesial to number 30. So there's like a little hole that has 3 walls all around the tooth. And that's the best kind of defect for regeneration. 2 walls usually, what do we call the 2 walls? What kind of defect is that? A crater. Okay? So the crater usually have a buccal and lingual plate, and in between there's a bone resorption. And most of the time the buccal and lingual walls are the same height. Okay? And this is the most common defect between the teeth. 1 wall usually is common also, but we don't do regeneration in 1 wall. And we have combinations sometimes. We have all the way at the apex of the pocket, we will have maybe 2 or 3 walls, and then as you come coronally, you might lose some of the walls. If it is shallow, then we can do accessory contouring. If it's deep, we will do regeneration. depends how shallow and how deep it is. And the narrower the defect, the better it is for regeneration. So if you have a huge wall, a huge defect, it's not going to be as amenable to regeneration that if you have a really thin defect and you're probing in and you can just fill it with bone and cover it with the membrane, it will be more effective. Okay, now, if you have your clickers, we're going to do some questions. Put it on 49. Did you bring your clickers? Yes? No? 49. Channel 49, or just 49. Are you ready? Yes? Palatal grooves occur most frequently in mandibular canines, maxillary first premolars, mandibular lateral incisors, maxillary lateral incisors. Palatal groove. Oh, it's saying palatal groove. So which one? Oh, it's still going.